expressions like anger, embarrassment, and are not perceived, and there is difficulty in identifying the positive and negative body language. And now I come, after this introduction, now I come to our role as ophthalmologists. As ophthalmologists, how can we assess, how can we treat and help in rehabilitating these unfortunate children? That is the topic of today's discussion. We have a responsibility to understand how far this child can use whatever little vision they have, and we have to share this information with the family members and others to promote development programs based on the findings of visual assessment. And we have to help determine whether the child will learn more effectively through auditory, print or tactile media, and to determine whether the child is eligible for services. We have to take into account caregivers' observations. The parents and caregivers' observations provide a valuable information that helps to interpret a child's use of vision. You have to ask leading questions to the caregivers. What do you think your baby sees? What attracts his attention? Can he control his head? Is he sensitive to light? Does he stare at light? Does he rub his eyes? These are all leading questions you have to ask the caregivers, and we have to elicit a detailed medical history on issues like seizures, medications they are taking, and also about the environment they are in, whether they are tolerant to light, whether we have to assess their performance indoors and outdoors. And coming to the screening tools, now WHO has published this PBL chart for assessment of children with blindness or low vision, this chart is developed by WHO in association with the International Center for Eye Health, and this chart has different sessions. Section A and A1 and A2 is concerned with the senses, like from where the child is coming, which state, which part of the country. And then the section B is for the demographic data about the age of the onset of the disease, family history, etc. And section C comes to the visual assessment proper. That is the job of the ophthalmologist. Section D is general assessment. Section E, previous eye surgery. Like that, several sessions are there. We have to fill up the whole thing and to give an adequate data. And there is a section for children with multiple handicaps also. I will elaborate on section C, or visual assessment, which is the most important from our point of view. A newborn baby up to the age of 6 to 8 weeks, the examination should include examination of the red reflex, corneal light reflex, general inspection of the eyes, and in some high-risk groups like this baby with rubella, you have to do special examination for eye problems. The visual acuity has to be found in a little more older children. Specialized charts are there. We have to dilate the pupil of all these children, and anterior segment examination is to be done by a handheld slit lamp. Then binocular indirect ophthalmoscopy, direct ophthalmoscopy, refraction is a must in all the kids, and ERG, VEP, MRI and CT scan is reserved for special cases. We should know what are the visual milestones. A small baby will have a lid closure to bright light even at the age of 25 weeks of gestation. Pupillary reflex to light occurs in 29 to 30 weeks. Tracking eye movements 31 to 33 weeks of gestation. And the acuity of a newborn infant is 6/240. Eye contact will be established at 7 weeks of age. After that, there is a rapid rise of acuity. Smooth pursuit movement, contrast sensitivity, symmetric occlusion all develops in 1 to 3 months. When you assess the red reflex, if there is a gross difference in the quality of the red reflex of both eyes, that is indicative of some problem. Here you can see that equal red reflex in both eyes is supposed to be normal. If there are opacities, it could be due to cataracts. If there is a asymmetric reflex, if one reflex is brighter and the other is dimmer, probably it's a strabismus. You can also detect retinoblastomas, high refractive errors by just looking at the reflex. And the assessment of vision is by fixing and following in the very small babies, and after that, if the patient is fixing and following, the CSM, the central steady maintained notation is to be noted. Central means the corneal light reflex will be only at the center of the pupil. Steady means if the light is moved slightly, if there is nystagmus, there is unsteadiness. Maintained is the ability to keep the eye fixed on a target. And these are two babies. the first baby, you can see that the child is almost blind. The child is not looking at the light. There is no good fixation and following. The child is not responding to light. Whereas the second baby is a normal baby. The second baby is able to look at the light. Fixing and following is good in the second baby. So that is how you compare. Here is another child. The child is able to fix and follow, but the fixation is central but is unmaintained. See that the patient has got nystagmus. So this is an unmaintained fixation and unsteady because of the squinting. There is an unmaintained unsteady fixation. Testing for OKN is better said than done. It is very difficult to keep the attention of the baby on the OKN drum. And in a slightly older children, we have to assess the visual behavior. Look at the way the child plays, the child keeping the object very close to the eyes. That will give a clue to the defective vision. And to assess the vision in a better way, we have the preferential looking cards. These are the teller cards, which are shown to the child, and by looking at the eye movement, you can assess whether the child is looking at that or not. In whatever way you are taking the vision, it's important to occlude one eye. The closure of one eye with the hand is not permissible. You apply a patch like this and ask the child to look at the cards. These are the Cardiff cards. And slightly older children, you can have the Logma cards, and the key card is always there. This is the Lee gratings and Lee pictures which are used. Logma cards, the key card. And for all children who are going to school, we should record the near vision also. These are the near vision and assessment charts. It's important to have electrophysiological tests. The visually evoked potentials are objective, non-invasive tests which can detect visual impairment, whether the child is malingering, whether there is a delayed visual maturation. It can confirm and prognosticate visual loss in encephalopathies, hydrocephalus, comatose patients, cortical blindness, etc. VEP acuity is better than behavioral estimates. We can have a flash VEP or a pattern VEP. If the child responds to a good size pattern reversal VEP to 50-second size, that means that's a good acuity. In small babies and mentally retarded, flash VEP recording in infants is good. This shows how to use a pediatric goggle to record the flash VEP in a baby. We can assess the amplitude of the P wave and the latency of the P wave and the N75 to assess whether the child has got defective vision or not. After that assessment, always we have to do the functional vision assessment. It is done by asking leading questions like and watching the child, whether the child can see enough to walk, or can see enough to recognize faces, or can see the print. Other additional things are about medical intervention. Medical intervention as early as possible has to be done. That will give a chance of visual improvement and will reduce the impact on impact. Surgical intervention for congenital glaucoma. This is a child with congenital glaucoma. You can see the corneal edema, hazy cornea, large cornea. These children has to be taken up for surgery as early as possible. Here I am happy to present one baby who came to us at the age of 2 weeks of age with the congenital glaucoma, operated successfully. Now the child is about 2 years and seeing well. Bilateral congenital cataract has to be operated in 4 to 6 weeks of time. Bilateral congenital corneal opacities. This child had presented with bilateral corneal opacities, underwent bilateral cornea transplant. In infants born with congenital corneal opacities, corneal transplantation in the first few months of life is the only chance of life. Only chance of light. And one word about pediatric screens. Infantile esotropia should be corrected as early as 8 to 10 months of life to attain a stable alignment and normal vision. It's important to take the whole family into consideration. Low vision aids are to be given whenever needed. and the emotional and social needs of the child has to be taken care of. We have to encourage parent-child interactions. And at one point of time, you may have to decide whether the child should be sent to a special school or a normal school. Now the preferred thing is to send the child to a normal school which has got an assistive technology, a magnification program for computer screens, Windows-based tutorials, Braille translation softwares, special programs to simulate human voice, etc. should be available even in the normal school. And nothing more can done is a fable of our times. Even though it may be true that nothing more can be done for the eye, it is almost never true that nothing more can be done for the patient. Providing rehabilitation services through visually impaired patient is the medical, moral, and will soon be the legal responsibility of all of us. Low vision rehabilitation services should start early and should be available as part of the routine care offered by every ophthalmologist. To conclude, a comprehensive approach to a child with low vision or blindness will involve a function-oriented history, specialized tools for ocular examination, customized approach based on the needs and expectation, and emphasis on psychosocial development. Before concluding this talk, I would advise or I would suggest that we should walk a mile in their shoes, then only we understand the real problem. We have lots of dreams, but the reality is facing us. Reality is staring us by this child. See, this is a 14-year-old child born with congenital cataract, did not receive medical attention even at this age. And we picked up this child in one of our blind school surveys. So this is the reality we are facing. Thank you very much for patient hearing. Thank you very much.